Welcome, guys. Hi, I'm Megan. I am here to tell you all about pharmacology and guessing that med. So I am not Jennifer. I know that that is on there, but I am not her. I am Megan. Can everybody hear me okay? Yeah, we good? Excellent. Okay. So, we're going to be using the chat tonight. So you guys have found that because you're answering me, but I would love to know oh, sorry guys, where you guys are calling from or joining me from. Where are you joining me from? Minnesota, Canada, California. Love it. Excellent. All right. Excellent. Okay. Well, I'm from PA, Southwestern Pennsylvania. I'm here freezing my little tutu off, my patootie off because it is cold and we're getting another snowstorm again. So thank you for joining me tonight. We are going to talk about pharmacology. So no, these are not recorded. So this is a free webinar. They are not recorded. Pittsburgh. Hi, I'm right outside of Pittsburgh. So we are not recording this lesson. This is a free webinar. We are going to be talking about guessing the medications. Pharmacology can be daunting, right, guys? It's a boring concept. We know that, and it's so much information we have to cover. So why not make it a little bit fun, right? So if we can change our thought process and making things a little fun, maybe we will be able to absorb some of that information a little bit more. So, what we're going to talk about is we're kind of going to do guessing the medication tonight. So, we're going to talk about, I'm going to give you like a little background and you're going to guess the medication. Okay? So, let's do this one. Ready? This medication is a first line uterotonic agent. Can you guys hear me? I think everybody else can hear me. So, when the line, it might be on your end. So this is a uterotonic agent used for both the prevention and management of postpartum hemorrhage related to uterine atony. It works by stimulating uterine smooth muscles, increasing the frequency and intensity of uterine contractions after delivery. This medication may be given IV via controlled infusion or IM. Continuous monitoring of uterine tone, lochia, and maternal vital signs is required during administration. Seeing tons of good answers in the chat. Hello to all my friends out there as we're live streaming on YouTube and Facebook. All right, guys. Yes, this is our oxytocin. Excellent. So oxytocin, remember, is a hormone that is produced in our body, right? And it helps do lots of kind of things, but it really helps an OB to help stimulate contraction. So we can give it a couple different things. We can give it during our pre-op our to induce labor. We can do it postpartum to do our to do contractions for hemorrhaging, and it also helps stimulate milk production of our breasts. So awesome job, guys. Love it. All right. So biggest things we have to remember is, especially if we're giving it to induce our contractions and induce labor, we really want to make sure that we are monitoring the contractions. So yes, this is the same as Pitocin. Yep. Monitoring our contractions because we want to make sure that it can really be a little bit more intensified. And we want to monitor the fetal heart rate to make sure that they're tolerating because those contractions are going to be a little bit harder. All right, guys. Just remember, we have our farm crash course. The next one coming up is February 16th. Amazing time to do it. I love our farm crash course. All right, so let's go on our next one. All right, ready? This medication is administered To a postpartum client who's Rh negative after delivering an Rh positive neonate. The client has a negative indirect Coombs test during pregnancy, and the newborn's cord blood confirms Rh negative, Rh positive status. This medication must be given to a specific postpartum time frame, about 72 hours after delivery, right? And may require additional dosing if large fetal maternal hemorrhage is suspected. Administration of this medication prevents maternal sensitization, which could otherwise lead to hemolytic disease of the fetus and newborn subsequent pregnancies. What are we thinking? Lots of good answers here in our chat. So if you guys are live streaming, what are you thinking? This is our ROGAM. Excellent. This is our ROGAM. This is it's a sorry, it's our ROGAM. Remember, guys, when we're giving ROGAM, the mom is Rh negative. Mom is Rh negative. The baby is Rh positive, right? And it can lead our baby to have erythroblastosis fetalis, and that is bad, and it can kill our baby. We don't want to do that, right? So basically what ROGAM is going to do is it's going to stop the mom's blood from making antibodies that are going to attack those Rh negative cells and Rh positive cells, right? This, I like to tell you this, guys, is given at 28 weeks gestation, between 26 and 28 weeks gestation, and within 72 hours after birth. This is considered a blood product, so take that into consideration whenever we're making sure that we're knowing who we can administer it to. All right, let's look at this one. This medication is a second-line uterotonic used to management of postpartum hemorrhage when uterine atony does not respond to the first-line therapy, which we already talked about. It works by producing sustained uterine contractions through direct smooth muscle stimulation. This medication is contraindicated in clients with hypertension, preeclampsia, or cardiovascular disease due to potent vasoconstrictive effects. Prior to administration, the nurse must assess blood pressure and continue closely monitoring for hypertensive crisis following dosing. Oh, I'm seeing a mixture of answers. You guys live, what do you think? All right, this is going to be our metrogen. Okay, so this is our metrogen. This causes those, it's a uterotonic agent, it causes those contractions. It can also be used to cause cervical softening and ripening. We also use this if we want to do an elective abortion. All right, next one. This medication is administered antenatally to a pregnant client at risk for preterm delivery between 24 and 34 weeks gestation. Its primary purpose is not to stop labor, but to accelerate fetal lung maturity by increasing our surfactant production. This medication is given as 2 IM injections, 24 hours apart. We're giving it to the mom. It can cause transient maternal hyperglycemia, and the nurse needs to monitor clients with diabetes or gestational diabetes very closely after administering. Excellent. This is our betamethasone. So it's our steroid, right? It's our steroids. So we need to be careful. That's why we need to make sure that we're monitoring with patients that have diabetes because it can cause hyperglycemia. Excellent job, guys. Excellent. Guys, I can't tell you enough. The Pharm Crash Course is amazing. We got to check it out. All right. This medication is prescribed for a client with bipolar 1 disorder who presents for routine follow-up. The nurse notes that the client recently started an ACE inhibitor for hypertension and reports nausea, coarse hand tremors, and new onset of confusion. Laboratory results reveal a serum level of 1.9, and the client reports decreased oral intake over the past several days due to GI illness. This medication is excreted by the kidneys, has a narrow therapeutic range, and requires consistent sodium and fluid intake to prevent toxicity. The nurse should recognize that changes in renal function, hydration status, and sodium balance significantly increase the risk for adverse effects. Awesome, guys. I'm seeing tons of good answers. Excellent. This is our lithium. This is our lithium. And our patient wasn't eating, decreased PO intake due to a GI illness, had some hand tremors. So we were actually looking at digitoxicity, especially if our therapeutic level was 1.9. Regular toxicity, guys, and can't stress this enough. Anytime that we have a therapeutic level, you need to know that 0.6 to 1.2 is normal level. Anything higher than that is going to be toxic. So we really need to be careful of that, right? Hyponatremia, dehydration can lead to that toxicity because lithium is a salt. Okay. And it is our main medication. It's a mood stabilizer, right? It's our main medication for our mania. So 0.6 to 1.2. Remember that one. Signs and symptoms of our therapeutic range, interventions we need to do, common side effects, greater than 1.2 but less than 1.5, nausea, vomiting, diarrhea, polyuria, lethargy. Annual assessment of renal and thyroid functions are really good with that. Early toxicities at 1.5 to 2.0, which is what our patient is. GIF set, right? Tremors, confusion, muscle spasms, EEG changes, and some sedation. So we want to hold that medication, check a dosage, and evaluate the dose. Advanced toxicity is 2 to 2.5. So we can have that ataxia, right? Confusion, blurred vision, large urinary output, hypotension, and we can lead to seizures now. Hospitalization at this point in time, especially because of the seizures. And then severe toxicity, which we never want to get to, is greater than 2.5, and that is going to be convulsions, seizures, oliguria, and it can lead to death, which is really, really bad. We don't want that. All right. This medication is prescribed for a client with major depressive disorder and panic disorder. The nurse notes that the client has recently switched from an MAOI with a history of polypharmacy, including migraine medications. This medication has exceptionally long half-life, resulting in self-tapering effects, but also prolonged drug interactions even after discontinuation. The nurse recognizes that combining this medication with other serotonergic agents significantly increases the risk of serotonin syndrome, which may present with hyperreflexia, agitation, diaphoresis, and hyperthermia. Due to its pharmacokinetic profile, a washout period is required before initiating any other antidepressants. This one is hard. I agree. What are we thinking, guys? What are we thinking? And I'm saying SSRI because there's certain means that they're serotonergic agents, risk for serotonin syndrome. I could go with that. So this one specifically is our fluoxetine, which is an SSRI, which we really have to be careful with. Now remember, guys, anytime that we are having a patient on an antidepressant, we really have to be careful to watch for increased signs and symptoms of suicide, right? Especially with those first 2 weeks, because they're getting the energy up and they want to be able to, they can full out their plans. All right, guys, so we talked about some OB medications, some mental health medications. So think about when you're studying pharm, you want to try to kind of make it a fun game, right? Make it a fun game. Try to think about different ways that we can think of this to be able to do it. When we're talking about other types of pharmacology, right? We want to make sure that we can really focus in on that. That Pharm Crash Course is going to be huge, right? Pharm Crash Course, huge. Try to do other types of fun things, or um, let's see here, what else can we do? The flashcards into our daily study plan is going to be good. Um, that's going to help too. But really want to try to kind of make that, because you want to try to be able to hone in on some of that information, right? Really hone in on some of that information. So let's cover a couple more of our pharm medications in our fun game that we're doing tonight. I know, so fun, right? Just what you guys want to be doing on a Thursday evening, with spend some time with me, right? I love it. Okay, so now we're going to do another category of all the bleeding stops eventually. So our free webinars are not on the Archer website. Okay, ready? This medication is used to prevent blood clots from forming in people who have certain medical conditions or who are undergoing certain medical procedures that increase the chance that clots will form. It is also used to stop the growth of clots that have already formed in the blood vessels, but it cannot be used to decrease the size of clots that are already formed. It works by decreasing the clotting ability of the blood. This medication stops thrombin from being activated. So stops thrombin from being activated. This is our heparin, guys. Excellent. This is our heparin. Excellent. So heparin is that thrombin inhibitor. It has an intrinsic pathway because it works inside the cells by converting or stopping the fibrin from forming. Guys, anytime our medication has an antidote, remember it. So our antidote for heparin is our protamine sulfate, and remember we have to do our PTT. So who all remembers the little finger trick with remembering what blood work goes with what anticoagulant? Right? We count our fingers, right? HEPARIN PTT, right? Excellent. Heparin is the only anticoagulant that can be given in pregnancy. It does not cause the placenta, but guys, it can only be given IV or sub-Q. Okay, so we always want to make sure that we are be careful of that. See, you learned something new, right? All right, now this medication is indicated for the use of pulmonary embolisms, venous thrombosis, and AFib. It works by disrupting liver synthesis of vitamin K dependent clotting factors. Excellent. Warfarin. So let's do our finger trick again. Ready? WARFARINPT. So that's how we can remember that. So we are checking our PT and INRs. And guys, here's another antidote. Vitamin K is our antidote for this one. Remember, this one has a slower onset, so if we are initiating them, we kind of have to do a bridge. So if we're taking our patient off of heparin and starting warfarin, we usually have to do that Lovenox bridge to kind of help between when the warfarin starts working. We really need to make sure that we are avoiding those green leafy vegetables because they're high in our vitamin K. See, I'm glad you guys learned something new with that finger trick. All right, next category, under pressure. Medications belonging to this class of medications are used primarily for the treatment of high blood pressure and heart failure. They work by causing relaxation of blood vessels as well as decreasing the blood volume, which leads to lower blood pressure, decreased oxygen demand of the heart. They work by blocking the conversion of angiotensin 1 to angiotensin 2, which increases our renin and decreases our aldosterone, which leads to vasodilation. This class of medication is often used for hypertension and CHF. This medication is known to cause a persistent dry cough in some individuals and can also cause flash angioedema. Seen tons of good answers. I actually saw a couple, guys, some of you put our couple of our examples in there. These are our ACE inhibitors. These are our prils, our lisinopril, our captopril, right? These are our prils. We really have to watch for that dry cough and angioedema. If that occurs, guys, we're discontinuing it. We're discontinuing those things. And again, anytime I'm giving a medication that's going to decrease my blood pressure, I need to always make sure I'm monitoring my blood pressure because it can go too low. And it's contraindicated during pregnancy. I can't give those ACE inhibitors during pregnancy. All right, next one. This class of medication works by blocking the transport of calcium into muscle cells, which inhibit excitation and contraction that causes peripheral dilation. What are we thinking these are? Our calcium channel blockers. Excellent. These are our calcium channel blockers. These are going to be our dipines. So our amlodipine, our nifedipine, and our cardipine, and then our ditalazam and verapamil are also on there. Calcium channel blockers, I need to avoid grapefruits and grapefruit juice because it blocks the enzyme from inhibiting it and can increase the direct levels of it. Again, monitor that blood pressure, right, guys? I cannot use calcium channel blockers with my beta blockers, right? And I cannot use calcium channel blockers in patients with congestive heart failure because it causes a sodium and water retention. So I don't want to give that to someone that's already having sodium and water retention issues, right? All right. Medications belonging to this class of medications can mask signs of hypoglycemia. We should never abruptly discontinue these medications and need to use them with extreme caution in those with asthma and COPD. What are we thinking on these ones? These are our beta blockers. These are our LOLs, right? Our propranolol, right? So remember, we have two different types of beta blockers. We have non-selective beta blockers and selective. Selective beta blockers are metoprolol or atenolol and esmolol are going to work directly on our heart beta adrenergic receptors. Our non-selective, we have beta adrenergic receptors in our lungs too. So those ones are not going to be specific to our heart. And that's going to be our labetalol and our propranolol and our carvedilol. We really need to monitor our heart rate because it can cause bradycardia. And our non-selectives cannot be used in patients with asthma because it actually can cause bronchoconstriction, right? And these ones we have to make sure that we are weaning off. We cannot discontinue them abruptly. And another fun fact is if your patient is taking allergy injections or needs epinephrine, they should not be on a beta blocker because that can actually decrease the effectiveness of our epinephrine. All right. These medications act at the ascending limb of the loop of Henle in the kidney. They are primarily used to treat hypertension and edema, often due to congestive heart failure or chronic kidney disease. Excellent. These are our loop diuretics. Excellent. Our furosemide, our torsemide, and our butymidine. This works on they are loop diuretics. Remember, they are our most potent antidiuretics. Most potent diuretics. They are also potassium wasting diuretics, right? So they are going to excrete our potassium also. So we really have to be careful that we're using them with care with our DIG and lithium because of those potassium levels and dehydration. Remember, we just talked about lithium, and dehydration can cause lithium toxicity. All right. Let's see. What else can we talk about? Um, this next one is going to be the medication works on our central nervous system and are used for a variety of medical conditions. They act on specific receptors in the brain called gamma aminobutyric acid A receptors. We are no longer on under pressure, guys. These medications attach to the receptors and make the nerves in the brain less receptive to stimulation, which has a calming effect. So we are back on mental health meds. Say lots of answers, but benzodiazepines are a correct answer on those ones. Our benzos, right? Our benzos are our PAMs, right? Gotta love our PAMs, our lorazepam, our diazepam. They are have tons of uses because they have such calming effects. So anti-anxiety, sedatives, anticonvulsants, right? They can use this to stop seizures. Um, it can give us a kind of a hangover effect, right? We never want to combine them with any central nervous system depressant, any other things, or alcohol. And again, guys, our antidote is our flumanazole. Another good one to remember. All right. This medication, again, we're still in mental health. This medication can cause neuroleptic malignant syndrome. Symptoms of neuroleptic malignant syndrome include a very high fever, irregular pulse, tachycardia, tachypnea, muscle rigidity, altered mental status, autonomic nervous system dysfunction resulting in high or low blood pressure, and profuse perspiration. Lots of good answers, I'm saying. So neuroleptic malignant syndrome. So this is going to be our haloperidol or our antipsychotics. Remember, haloperidol is a typical or first generation antipsychotic, right? So usually we give these for bizarre behavior. They really increase our dopamine levels in our brain, but they have those anticholinergic side effects, right? Remember our anticholinergic, what's the poem for our anticholinergic side effects? Can't pee, can't spit, can't see, can't poop, right? Um, Haloperidol is more potent. We really have to be careful that we're watching for signs of our extrapyramidal syndromes and our tardive dyskinesia, right? We really have to be careful with that. So they really like to try to use our atypical or second generation antipsychotics because those risks are a little bit lower. All right, guys. Thank you so much for joining me today. I really appreciate it. If you guys have any questions, make sure you email nclextutors@archerreview.com. Thank you so much for spending the last half an hour with me. I really appreciate you guys joining us, and I can't wait to see you at other Archer Review resources. You guys have a fantastic rest of your day.